It is a pleasure to introduce Silvana Quaglini to do this seminar for us. She's qualified as electronic engineer and PhD in bioengineering, and she's a full professor of medical informatics at the University of Pavia, Italy. Her research focuses on decision support system, home monitoring and care, and electronic evaluation models of healthcare interventions. Her application area include cancers, stroke, and chronic diseases, and cognitive rehabilitation. In recent years, she's been concentrating towards personalized medicine and directed the latest study towards shared decision-making and context-aware home monitoring. She's consistently conducted applied research, mainly with EU-funded projects, collaboration with local and international hospitals. She's a past president of Italian Society of Biomedical Informatics, European Federation of Medical Informatics, a member of the National Bioengineering Group, and author of approximately 38 scientific publications, 350 scientific publications, with HR index of 47. Her collaborators include Silvia Mikish, Mario Stefanelli, Moria Peleg, Yoga Shah, Riccardo Palazzi, and these are distinguished international medical informaticians. And Samson Tu from Stanford as well. She was a keynote speaker in the 40th anniversary of Conference in Artificial Intelligent Medicine in Pavia. This conference started in Pavia in 1985, and last year was the 40th anniversary, and Silvana was a keynote speaker. It is a pleasure to have her to give us this talk on digital technology and personalized care pathway. And thank you very much. The floor is yours, Silvana.
Thank you, Abdul. Thank you very much for this invitation. I'm very happy to give this seminar. And thank you also for the presentation, too kind of you. So welcome to everybody. I will talk about digital technologies and the ways to personalization of those digital technologies. So I start with a terminology issue. Often we talk about personalized medicine or precision medicine in an exchangeable way. I would like to point out that for me, precision medicine is that area that through genomics and all the omics sciences try to personalize treatment for patients, for example, to produce drugs that are personalized according to the genetic profile of a patient. While personalized medicine is a more let's say holistic concept, dealing with well-being, so nutrition, physical activity, mental well-being, all those things that can be personalized to the specific patient to be more effective. So in my talk, I would talk about this more holistic concept of personalized medicine. And in particular, since the area is very, very wide, I will concentrate on two contexts. The first one is the framework of telemonitoring and digital therapeutics, and the second one, the after-visit summaries. So let's start with the first one. Digital devices for home patients are my specialties, let's say. And just to start and to see what I mean for home patient monitoring, I have a very short movie. It's just 1 minute and a half that presents this project Capable that I was coordinating from 2020 to 24. So it finished 1 year ago. Unfortunately, since this movie was prepared, the application is in Italian because it was for Italian patients. So the movie is dubbed in English, so I hope you will understand also what it's written in the images. So I just start the movie.
Capable is an innovative solution created thanks to funding from the European Union and developed by a team of multidisciplinary experts led by the University of Pavia to improve the quality of life for cancer patients. Capable uses telemedicine and artificial intelligence to monitor physical and mental well-being, including nutrition, helping patients to become more aware of their state of health and therefore manage it better. Thanks to a smartwatch and a mobile phone app, the patient is monitored and assisted throughout the day, with reminders for taking medication and hospital appointments. If symptoms arise, the app allows the patient to communicate them immediately to the doctors, including the location and level of intensity. A virtual assistant takes charge and provides simple suggestions while waiting for the doctor's intervention. The virtual assistant also offers virtual pills, that is, non-pharmacological interventions consisting of activities capable of improving psychological well-being. With Capable, the oncologist and colleagues from the multidisciplinary team can detect early signs that require an adjustment of care and offer personalized suggestions from which the patient can benefit immediately. Capable was developed by a team of bioengineers, doctors, psychologists, and nutritionists with the aim of improving the quality of life for cancer patients and their home caregivers. The Capable application has undergone a rigorous validation process and has proven to be effective and of great help to patients.
Okay, so just to give an idea of what these telemonitoring applications are. In particular, this was a telemonitoring application for cancer patients. We had in this project 2 hospitals participating, one in Italy, in Pavia, and here renal cancer patients were considered, and the other one was in the Netherlands, the National Cancer Institute in Amsterdam, and they participated with the melanoma patients. Considering this kind of applications, Capable is just one of them, but there is a lot. There is some evidence in the literature that telemonitoring increases also life expectancy in a selected patient population. And I reported some results from the literature. This was a very important paper from Ethan Bush. Ethan Bush was a pioneer in the patient-reported outcome research. He's from Carolina University in the United States. And for the first one in 2017, they demonstrate that collecting outcome from patients through, in particular, through electronic devices could not only improve the management of the patient, improve the control visit efficiency and so on, but even survival. For example, you can see these survival curves where the median overall survival was about 31 months in the patient-reported outcome group and 5 months less in the usual care group. This was a very important result. there are other results. The same group 2 years later demonstrated through a trial that 2-year survival also was improved. Here you can see two different curves. One is the intention to treat analysis. The other one is the censoring of crossover analysis, because some of the patient in the usual care group cross to the other group during the analysis, during the trial itself. But in any case, whatever the statistical analysis type, you can see that the web-based monitoring, in fact, improve the survival. And in this case, it's about 8 months of gain. So also this is a very nice results. In our experience, we, in the Capable project, we observed the patient for 6 months of a follow-up. So we couldn't detect an improvement in survival, but it was not our purpose. Our purpose was to see if the quality of life was increased. And in fact, you can see the results. The red one are the patients undergoing telemonitoring with the Capable system. The blue one is the usual care patient. And you can see that the quality of life in the Capable group increased, and this difference in these two trends is significant. In particular, looking at considering the side effects and the problems given by the disease, the most important results was about fatigue. Fatigue is one of the issues in cancer patients that is very, very common, and it is due both to the disease, because cancer, there is the so-called cancer-related fatigue, and to the effects of cancer treatment. And as you can see, fatigue is decreasing in the Capable group, while it is increasing in the usual care group. We try to explain these results, and since the application fosters patients to do, for example, physical activity, to do activities for socializing, for going outside, and so on. Probably, since it is proved that physical activity improves this symptom, we explain these results in that way. This is another app similar to the Capable one. It is called Curity, and it is quite widespread in Europe. And they also demonstrate that collecting the side effects of the therapies through this application improve the management of the patient. In particular, it's interesting to see that among this high number of side effects reported by the patient through the app, almost 1/3 deserve consideration. No? The yellow one is compromised patient, the pink one is to be monitored, the red one is critical. And these findings are in between visits. So those are findings that couldn't be detected through the traditional patient management. So monitoring also these findings led to, for example, a decreased number of rehospitalization. And also in this case, the progression-free survival was demonstrated to be higher than the usual care one. However, so this kind of applications seem to be effective, to decrease cost, to improve survival, to improve the quality of life. And if we think about this, if the same efficacy figures, so improving survival of 8 months, improving quality of life, if the same figures were found about a drug, probably we already had this drug on the market for a few years. So why it is so rare for the digital therapeutics to enter the market? Because almost all the applications that are described in the literature are applications developed in research projects. And it's rare that after a research project, even if the results are good, it's very difficult to translate those results into the clinical practice. So why? If we look to the FDA-approved digital therapeutics, I prepare some slides for United States and some slides for Europe. This is produced using ChatGPT, but I also checked some of the results in the literature. So this is these are true results. And if we look at the applications that have been approved by the FDA as digital therapeutics, that means applications that can be prescribed, like a drug. So sometimes you can prescribe an application because it has been demonstrated to be effective, as it was a drug. And you see that with respect to the number of drugs that have been approved, there is a very small number of applications approved. Most of the very first one was approved in 2010. It was Blue Star. It was for diabetes, and most of the first ones were for diabetes. Why? Because diabetes, being a so common disease, there has been a lot of research about diabetes, and the research on the technological side, because one of the major purpose was to develop the sensors for continuous glucose monitoring that now are on the market, but they required tens of years of research. So being this technological research going on for diabetes, we can understand that the very first applications were developed for those patients. And then we have other applications for other diseases, for example, for insomnia, for the disorders related to children hyperactivity, depression, post-traumatic stress disorder, again diabetes, asthma. I go very quickly, then you can, I leave the slide so you can see on the slide. Chronic back pain, fibromyalgia, and so on. I would like to highlight this one because it is a very widespread application that has been approved for substance use disorder in 2017. And you know, in these years, the problem in the United States, for example, with oxycodone, so this was an application for those kinds of problems. In Europe, we also have some applications on the market, but again, almost all of them are in Germany. This is one for back pain. That one is for chronic obstructive pulmonary disease. Then I have a list also for Europe. More or less, the diseases are the same: the depression, pain, insomnia. In Europe also overweight is addressed. You can see that apart from the last one, that is for diabetes, all the other ones are approved in Germany. Why? Because differently from the other countries in Europe, in Germany there is this DIGA, DIGA system, Digitale Versorgungsgesetz, that is a workflow, an official workflow devised by the government that the applications should follow to be approved. The regulations that the applications must comply with are the GDPR, about the privacy, the MDR regulation, the medical device regulation, and for those applications that use artificial intelligence, now there is also the AI Act that must be complied with. This poses some problems because these regulations are to be applied for the same device and they have to be harmonized for applying for a full application, and this is not so easy because they have been written by different organisms. So, okay. This can be one of the problems hindering the jeopardizing the widespread of these digital therapeutics. Another problem is this one. One of the main steps of this workflow is to answer positively to this question. Does the application provide positive care effects? For example, medical benefit, structural and procedural improvements. So this means that to be approved, the application must be must undergo clinical studies and proved to be effective. So we know that apart from a research project where you can, for example, do a pilot study with 50, 100 patients, to prove that the application is effective in the population, you need much more patients. And the clinical studies are very expensive. So this is another motivation why the spreading of these applications on the market is not easy, because for the drugs we have the pharma, we have the pharmaceutical companies that fund the clinical studies. But for the application, it's more difficult to find a funding organism that allow to demonstrate the efficacy and the effectiveness of this app. Even an app is approved, imagine that we are able to fund a very big clinical study and to demonstrate that this application is effective, it improves survivals. Even if it is approved and even if it is prescribed, there is another issue, and this issue is adherence. In fact, if we look at the literature, we see that, for example, this is a systematic review taking into account almost 100 papers, and the estimated adherence is not so high. You see, 56%. So this means that once the patient has the app available, often he doesn't use it. Why? If we look at the motivations reported by this systematic review, we see that 3 of them are related to personalization. Personalization or adaptation of app content to the individual user needs, reminders in the form of personalized push notification, need of a wide range of social and gamification features that, of course, are different from a patient to another one. And in fact, the variety of patient preferences is so wide. The results that now I'm going to show you are from a focus group that we held in Pavia in 2023 at the end of the Capable project. And these are sentences reported as they were from our patients. So one patient say, the less I know, the better I feel.
Yes.
Another patient say, transparency and clarity are better than being limbo, even it's tough. I trust what the doctors tells me and don't need to know anything else. I want to share my perspectives with my oncologist, especially regarding potential new treatments. In psychological questionnaires, I would have preferred to write free text instead of giving scores. For me, giving a score actually helped me reflect more deeply on my symptom. It scares me a little to think that in some psychological questionnaires, my score could exceed the threshold. I would have appreciated a wider choice of relaxing activity, for example, the option to add a personal playlist. So apart from these 2 last sentences, you can see that the other ones are in the left exactly the opposite that in the right. No? So the patient preferences are really very difficult to capture and to comply in the same application. But of course, they have to be taken into account because if we do not take into account the personal preferences, then the patient will not use the app. So summarizing, when the apps have been shown to be effective, they can be approved. And we have the problems in demonstrating that they are effective. Once approved, they can be used and sometimes even prescribed if the country regulation allows it. When they are used, they can be effective because there are demonstrations that they improve both survival and quality of life, but to be used widely, they need to be personalized and appealing to users. So, how to personalize? Now I will show some ways to personalize the applications. There may be some very simple approaches and some more sophisticated approaches. The very simple one is to use symbolic AI, the old rule-based artificial intelligence. If condition, then conclusion or action. This is a rule, and the old artificial intelligence, the one with the one that led to the expert systems in medicine, was entirely based on rules such as this one. And I start with an example. This is another project of ours. MobiGuide was a project for monitoring patients with atrial fibrillation. And I will show you a reminder for a drug. So in this application, when the patient see the email boxes open, that means that there is a recommendation. So the patient opens the box, and the recommendation is it's time to take paracetamol, a tablet. And this recommendation arrive at 7 p.m. Why this recommendation arrive at 7 p.m.? Because in this application, the reminders are on. The meal time declared by the patient, when we profile the patient, we ask, what time do you have your breaks? What time do you have your lunch or dinner? And these are the meal time for Mr. Rossi. 7 o'clock the breakfast, 1 o'clock p.m. The lunch, and 8 o'clock in the afternoon the dinner. So now we are 7 o'clock, 1 hour before the dinner meal time, and the reminder arrives because this medication must be taken on an empty stomach. So the system embeds this rule. If the prescribed drug is in the list of medication to be taken on an empty stomach, and the current time is the meal time minus 1 hour, then send a reminder to take the prescribed drug. Very simple. These meal times can be personalized also according to the context, because probably Mr. Rossi, when he's on vacation, wake later, so everything is delayed in vacation. Or when Mr. Rossi is hospitalized, those reminders are off, because meal times are the times of the hospital. Okay, so this is a very simple way to personalize something. Which is the problem? As for any rule-based system, this system is based on a database where we have the drugs prescribed to Mr. Rossi, and a knowledge base, for example, in this case, containing the medication to be taken on an empty stomach. These are data, this is knowledge, and a rule is activated by matching the data with the knowledge. Of course, this is a very simple example, but you can imagine more complex example. The principle is the same. Which is the problem? The problem is that it's not very flexible, this approach, because the rules cannot be updated frequently, in the sense that if Mr. Rossi one day wants to eat at 2 o'clock instead of 1 o'clock, the system doesn't work properly, and it's impossible to think changing a rule every day, no? So which are the possible solutions? Nowadays, we have a lot of sensors that can take your weight, your blood pressure, your glucose, your temperature, and so on. And in particular, I found in the literature, just to stay with the same example of taking a drug according to the meal times, I found this very interesting paper that the title is Detecting Eating Episodes from Wrist Motion Using Daily Pattern Analysis. In this paper, the authors developed a machine learning algorithm for meal recognition using an open data set. In this data set, there was data about more or less 350 people that for a certain time wore a motion tracker. You can see this smartwatch here. And when they take their breakfast, dinner, lunch, they just click a button to annotate, let's say, the fact that they were eating. So the authors had available something like that. These are the signals, the time series of the signals, and these time series are annotated with the meal times. And from this open database, they learned they trained this algorithm that was able at the end to recognize the meal time and also to estimate the meal duration. So, assuming that the algorithm performance is acceptable, how we can use this information? We can ask the patient to wear a smartwatch like this one, and we can use this model, this predictive model, to understand whether the patient's habits are changing. So the profile of the patient regarding the meal times can be changed dynamically. We can predict when the next meal will occur and dynamically change the timing of the reminder. And we also can see if the patient is taking the medication accordingly to the indication of his physician. So the rules are still there, but become dynamic thanks to the predictive algorithm. So the rule become, if the prescribed drug is in medication to be taken on an empty stomach and the current date time is the predicted meal time, here is the artificial intelligence contribution, minus 1 hour, then send the reminder. In this way, the person is no longer constrained by the initial profile, but it is she's free to change his preferences over time, and the system dynamically adapt to this preference change. We say, assuming that the algorithm performance is acceptable. This is a warning, because we know that algorithms are not perfect. So I showed before a very good performance of the algorithm, but the authors, in fact, showed also this pattern where we see a false positive. The algorithm detected something that is not, in fact, a meal. Why? Because we know that if the training set is, for example, from Asia, where the eating is doing like that, or if the learning set embeds people that prepare the meals by themselves, and then I want to apply this algorithm to people that eat with fork and knife, or to people that always eat at the restaurant, maybe the algorithm is not so good in predicting the meal time. If the person he was trained on are very different from the person he was applied on. This is the problem, the very well-known problem of generalizability of predictive model, their external validity. We know that there is a lot of literature on that. I do not stay so much on the problem, but just to cite it. Another use case, personalization of the side effects management during oncological treatment. Still, I come back to our Capable project. Here, we also ask patients to wear a smartwatch, and through this smartwatch, we measure temperature, saturation of oxygen, blood pressure, heart rate, activities, sleep. Then we provided the machine learning system with all the time series of all the signals measured by the smartwatch, and we provided also the symptoms entered by the patient through the app. We found that looking at the time series of oxygen saturation, after a few days with the decreasing SpO2, the patients entered the fatigue symptom. Sorry, it's in Italian, but this is the fatigue symptom. This is not for every patient. So the model is able to learn from individual patients' data in order to be able to make a prediction for the specific patient. So for a specific group of patients, decreasing SpO2 predict fatigue. This is very important because if we are able to predict a side effect that would have been entered some days or some weeks afterward, we have time to prevent that side effect. For example, to suggesting patient to do more physical exercise and so on. This is a discussion point. Could personalization lead to excessive monitoring? We just saw that through those sensors, now we are able to measure everything. And with the user consent, of course, we can also see from the mobile the daily hours spent on socials, the number of interactions, how many likes, how many comments, everything. So it's true that this can be very useful because through this data, you can use those data for doing a behavioral analysis. So if there is a psychologist, for example, behind the app, the psychologist is able to understand that there is something going wrong and intervene. It's true that you can give very useful feedback to the patient, alerting them, suggesting them to decrease, for example, the time spent on the social and so on. But of course, we have to avoid the big brother effect, because if the patient feels to be too much monitored, maybe there is this effect that makes it makes him to throw out the application. This is just a discussion point. The other area where I would like to show you how we can personalize is these after visit summaries that are becoming very, very common in the literature, because with those large language model invading all our life, everyone understood that we can give a report, a medical report, to a large language model and ask the model, the LLM, please rephrase this report in a way that is more understandable for a specific patient. This is the context. And I report this just as an example. This report, this is my my ultrasound examination of parotids, so no privacy issues here. The parotid and submandibular glands show normal ultrasound findings. Only a millimetric lymph node, 5 millimeter, is noted within the superficial portion on the right parotid, appearing reactive. No lymphadenopathy is observed along the lateral cervical chains bilaterally. Following total thyroidectomy, no masses are visible in the thyroid bed. Okay, this is the original version. Now I ask ChatGPT, can you make a simpler version? And this is the simpler version delivered. Your salivary glands look normal. Note that in the official version, the term salivary was not present, but is much more common, no, for the normal people. Again, this reactive term, maybe not everyone is aware what does it mean reactive, talking about a lymph node. Reactive means benign. So it is translated as a very small lymph node, which is not concerning, and so on. So in this first version, we see the same information, but rephrased in a way that is more readable, more comprehensible by lay people. I ask even simpler, and this was the result. Your salivary glands are healthy. A very small harmless node was seen in the right gland. Nothing unusual or swollen was found in your neck. Here you see that the information is still there, but not completely, because, for example, the thyroid surgery here is not mentioned. That could be an information that for a physician could be useful, but not for the patient, because he knows very well that he underwent that surgery, no? I ask even more simpler, and this is the very last rephrase. Your salivary glands are normal and no problems were found. Note that this was these rephrasings were delivered just asking a simpler version, and then even simpler, even simpler, even simpler, without giving any profile of the patient. So this is a good result, but imagine what we can do if in the prompt for the large language model, we also add the profile of Mr. Rossi, the age, the scholarity, the medical literacy, the mother tongue, no, because of course the same sentence can be translated in every language we want. The psychological questionnaire score, so the language may be also adapted to different psychological profiles. And we can also improve the phrasing by reporting the rating that the patient himself gave to previous report. So in this way, we will be able to generate a real personalized, tailored report, and we are working on that in our current research. As I said, this is a very hot topic in the literature in this year. For example, as you can see, it is a very recent literature. I reported 4 papers. In the first one is interesting because it showed that using these after summary reports simplified and tailored to the patient, the average communication time decreased by 70%, probably because the patient reading a readable report doesn't ask anything or less to the physician, and so the time of the visit can be shortened, or the same time employed for more interesting things. This is interesting because it not only underline that the report generated are good, but also some warning, because here, in addition to rephrasing the report, the authors would like also to add some suggestion for changing the lifestyle. And generating lifestyle recommendation is much more difficult than rephrasing a report. This was also interesting because it highlights that LLMs still have some problems for hallucination. And this one is interesting because they use WhatsApp sentences written by the patient in order to understand the patient's style, let's say, and generate a report in the same style. Which are the risks in case for this in this area? I see some risks in case of patients with an avoidance-prone profile. You know, avoidance-prone profiles are those patients that don't want to know everything, no? That they don't like the full transparency about their condition. So in that case, there is this risk because LLMs tends to please the user, to comply the user, and not disappoint them, because they are trained for that. And in this area, in a medical area, and in particular when rephrasing a report, this can lead to minimize some real risk, giving an overly reassuring impression when in the reality there are something that is going wrong. No? And in complex cases, this might oversimplify or omit important things, as we saw in the report, in the rephrased report of my salivary glands, then where thyroidectomy was omitted. So in conclusion, personalization requires collaboration with patient for the system design and validation, because we saw that the preferences are really different. Personalization doesn't mean necessarily please the patient, but we have to find a compromise between please the patient but saying the thing as they are. And a last point is that personalization introduces an additional variability into the systems, which consequently make the implementation of regulations more challenging. I mentioned the high number of regulations that we have to follow to put on the market this kind of application, and personalization add complexity and add problems in applying those regulations. Thank you. I'm finished.